and welcome to my presentation on schizophrenia by Amy Bennett. In this presentation we will discuss the history of schizophrenia, the classifications and different types of schizophrenia, the biological, psychological and social explanations for schizophrenia, and the biological and psychological treatments for schizophrenia. The Greek name schizophrenia came from two words meaning split mind, although this is not to be confused with multiple personality disorder. What we now call schizophrenia was originally called dementia precox, meaning senility of youth, by Emil Kraepelin. He grouped together symptoms as a progressive disorder that could only lead to a state of chronic impairment without a chance of full recovery. The symptoms that he emphasised included auditory and tactile hallucinations, delusions, incoherent speech, blunted emotions, negativism, and stereotyped behaviour. Nonetheless, the difficulty and complexity of classifying the disorder was not disregarded by Kraepelin, who was quoted, explained, In spite of all efforts, it appears impossible at present to delimit them sharply and to assign each case without objection to a different form. Following observations from Eugen Bleuler, he introduced the term schizophrenia in his publication of Dementia Precox, or the Group of Schizophrenia, in 1911, describing the loosening of associations and of different functions in the mind of the schizophrenic, which results in disconnection and loss of coordination. The term schizophrenia remains widely recognised in psychology, with 1% of the population affected worldwide. Classification and different types of schizophrenia. Schizophrenia is defined in the Diagnostic and Statistical Manual as a severe and chronic mental disorder characterised by disturbance in behaviour, thought and perception. Here are the DSM-5 criteria for schizophrenia. These symptoms all have a great deal in common and require evidence of psychosis occurring currently or in the past. It is important to recognise that the DSM-5 requires symptoms to manifest for a period of 6 months, whereas the ICD-10 only requires symptoms to be showing for 1 month. Symptoms of schizophrenia vary depending on the individual, and they can be positive or negative. Positive meaning the presence of symptoms which differ from the norm, showing a pathological excess, whilst negative symptoms refer to the absence or lack of normal mental function. The first-ranked symptoms were first characterised by Kurt Schneider in 1959, defining the central features of the disorder. There are different types of schizophrenia, type 1 and type 2. Type 1 schizophrenia is mainly composed of positive symptoms. Typically, this has a later onset than type 2, with a better long-term prognosis in terms of the effectiveness of drug treatment, as there is greater evidence showing the involvement of brain biochemistry. On the other hand, type 2 mainly involves negative symptoms. It is associated with brain structure abnormality, hence the lesser effectiveness of drug therapy. Prognosis is less optimistic than in type 1. As classified in the DSM-5, there are different subgroups of schizophrenia. These are disorganised schizophrenia, characterised by displaying many of the symptoms such as hallucinations, delusions and thought process disorder. Catatonic schizophrenia. This is characterised by excited, sometimes violent motor behaviour, or becoming mute and almost immobile. They can alternate between the two, but usually one behaviour dominates. Then there is paranoid schizophrenia. This is the most common form of schizophrenia, and it may develop in later life than the others. This involves delusions, often associated with feelings of conspiracy and paranoia. It may also be associated with auditory hallucinations, which can cause aggressive acts due to the delusionary paranoia. And differentiated schizophrenia, when symptoms are showing but the patterns of behaviour do not fit into any other category. This is a broad category where symptoms of other subgroups may overlap. Then there is finally residual schizophrenia. In this category, there are no positive symptoms present, but there has been a history of psychosis, and the negative symptoms are still showing. As recognised, there can be an overlap of symptoms between the categories of diagnosis, and this is called comorbidity. So now we'll discuss the biological explanations for schizophrenia. In recent years, emphasis has been upon biological causes for schizophrenia. What causes this mental disorder has been a focal point for controversy surrounding the medical model, and as quoted by Alois Alzheimer. Despite 100 years' research, the neuropathology of schizophrenia remains obscure. The first theory to discuss is the genetic theory. Hereditary factors have always been an important etiology of schizophrenia, with the first study of familial occurrence undertaken in Kraepelin's department. The demonstration of the genetic component has been continually investigated since. By pooling data from a large number of studies out in Europe between 1920 and 1937, Irving Gottesman was able to show that the general 1% risk of schizophrenia to the population increased to 48% when an identical twin had the condition, and 46% in the offspring of schizophrenic parents. There have been numerous amounts of twin studies showing differing amounts in the percentage concordance rates for both identical and non-identical twins. However, it still remains the case that those genetically nearer to someone who suffers from schizophrenia will be at a higher risk. The difference in the results could be due to the factors such as different severities of the disorders within each study. In a more recent study, Joseph found that the concordance rates for identical twins was 22.4% and for non-identical 4.6%. However, as families share environments as well as genes, psychologists have been debating the environmental impact. A second method of research looks at children who have schizophrenic parents but were adopted at birth. The investigation showed that adopted children were still at a greater risk if their biological parents were the schizophrenics, showing the enhanced tendency was not due to the environmental factors. Whilst genetic factors clearly play a role in the development of schizophrenia, there has still been no single gene identified as the marker for schizophrenia, and no conclusive evidence that genetics are the sole factor. As Gottesman reviewed, 89% of patients do have parents who are not schizophrenic, and 63% show no family history at all. A further explanation is the biochemical factors. It has been proposed that what directly causes schizophrenic symptoms is an excess of the neurotransmitter dopamine, known as the dopamine hypothesis. Dopamine excess is seen as particularly responsible for type 1 symptoms. This evidence for this hypothesis came from multiple sources. These are postmortems on schizophrenics showing unusually high levels of dopamine, especially in the limbic system, as seen by Iverson in his 1979 study. Another source was that drugs that effectively block dopamine transfer by binding receptor sites reduce the schizophrenic symptoms too. However, amphetamines and a well-known drug used for Parkinson's disease both enhance dopamine release in the brain. Those who take amphetamines for a long period of time can acquire drug-induced psychosis, similar to the symptoms of schizophrenia. Again, there is evidence to implicate the responsibility of brain biochemistry, but it does not establish causation. Schizophrenia may be the cause of the chemical imbalance, and the exact neurochemistry is not clear, with drug treatment being ineffective for some schizophrenic patients. Other biological explanations include the evolutionary explanation and the brain structure in early development. There are three psychological explanations to be considered for schizophrenia. Firstly, there is behaviourism. The concept of behaviourist belief is that all behaviour is learnt and can therefore be unlearnt through operant and classical conditioning, as seen in Ivan Pavlov's infamous dog experiment. It is where a previously neutral stimulus is paired with a conditioned stimulus to create a conditioned response. Operant conditioning is the process of learning through reinforcement and punishment, weakening or strengthening behaviour, defined by B.F. Skinner. Behaviourists essentially believe that schizophrenia is a result of improper environmental conditions, which have led to improper mental functioning. Psychologists who act upon the behavioural perspective believe that poor reinforcement in the life of the patient caused for overgeneralisation and interpretation of certain environmental cues. As Ullman and Krasner explained, schizophrenia results from the extinction of attention to social stimuli which normal people would respond. They also found that in an inpatient ward, schizophrenic patients gave more attention. When rewarded with sympathy, they will continue to act this way. This perspective solely focuses on the nurture in the nature vs nurture debate and disregards the complexity of mental processes which are vital when developing mental disorders. Schizophrenia cannot simply be learned, but behavioural interventions can help patients to modify their behaviour. Then there is the psychodynamic approach. This approach looks at the psyche and subconscious mind of the individual and how the elements of their personality have been shaped by experiences which led to psychosis. In Freud's theory, he identifies the ID, the ego, and the superego. The ID is present from birth and is the primitive, instinctive part of the personality. It is based on biological drives such as eating and sleeping. Operating through reflexes and primary processes, the ID forms associations of objects with fulfillments of needs. The ego is the rational part of the psyche, developing when a child is around 1. Obeying the reality principle, it makes decisions taking the constraints of the real world and recognises unrealistic demands of the ID. The superego is the final part of the personality that develops between 3 to 5 years, but may still develop into later adolescence. It is built upon internalisation of social norms and values. The psychodynamic explanation for schizophrenia is that the ego has difficulties identifying distinctions between the self and the external world, creating a distorted reality. It also states that an individual has regressed to become dominated by the ID known as primary narcissism. In this state, the individual cannot identify between what is real and what is fantasy. The psychodynamic theory focuses on unresolved conflict in early stages of development, with Freud pressing the notion that if the primary caregiver were uncaring, the child would slip into their own fantasy world as a defence. They also focus on the double bind theory, put forward by Bateson in 1956. This theory is however largely untestable scientifically, as it is based upon abstract ideas. However, it was the first theoretical attempt to understand this disorder, and this has paved the way for further developments in the research and for the sufferers of schizophrenia. The cognitive explanation provides a useful link between psychology and biology. It is based on the notion that the emotions of an individual are intrinsically linked with how the brain works. The recent advent of brain imaging techniques allows for further evidence of how the brain responds to certain stimuli, gaining better understanding into the minds of schizophrenics. Then there are the social explanations for schizophrenia. Life chances and choices may play a vital role in exacerbating the risk factors of developing schizophrenia. In major life events that cause emotional stress, such as divorce, bereavement, or accidents that are damaging to livelihood, they can become a trigger for the onset of symptoms. Other factors with potential influence are where the individual lives or the socio-economic group to which they belong. Firstly, we will discuss life events. Studies of life events were pioneered by George Brown and Jim Burley in the late 1960s. They counted life events over a period of 3 months prior to the acute episode of schizophrenia. In the study, they found that 50% of those that had had an episode had experienced at least one major disruptive life event in the previous 3 weeks. They concluded that the stress of the disruptive life event triggered the onset of schizophrenia. However, studies of this kind are difficult to interpret, as it is possible that life events such as job loss are a consequence of the illness rather than the other way round. There are also other limitations, as the self-reported events from the patients are subject to a distorted sense of reality of timescales. The limitations were identified from the original studies, with further research carried out, finding that there were 23% risk of relapse due to the life events that year. Then there is interpersonal family communication. The double bind theory, mentioned in the psychological explanations for schizophrenia, considers the notion of the schizophrenic mother. The theory of the mother sending conflicting messages to the child through ambiguous behaviour fell out of favour for a while, but has been associated with other family communication theories, as those suffering from schizophrenia are very susceptible to confusion and mixed messages from their family. High expressed emotion is an important aspect of interpersonal family when considering the effects of family communication, family environment on the schizophrenic and their chances of relapse. Kavanagh found that an individual was nearly 4 times more likely to suffer if living in an environment of high expressed emotion. However, this is not to be confined with schizophrenia and provides a greater indication for illnesses such as depression or eating disorders. It is unclear if high levels of emotion causes a relapse, or if those suffering and in a weakened psychological state provoke higher levels of expressed emotion from family members. We will now discuss the biological therapies for treatments of schizophrenia. Biological therapies include drug therapy, falling into 2 bands, typical and atypical drugs. Typical drugs block dopamine within 48 hours of taking them, assuming this will reduce schizophrenic symptoms. These are highly effective for treating positive symptoms of the disorder, but this relies on finding the correct dosage for the patient and their compliance when taking medication. It is unlikely that in the early stages of the illness they will have reached the level of self-insight to comply with the medication procedure. Issues with efficacy are also due to the intensity and dangers of the side effects of antipsychotic drugs, which will be shown within the slide. Drug treatment can be effective in a variety of ways, reducing the individual's symptoms and to enable them to continue a normal life, reducing the risk of harm to themselves and to others. But it's important to recognise that approximately 15% do not respond to the new antipsychotic drugs, and drug therapy does not work for everyone. Electroconvulsive therapies were used regularly, but since the advent of newer antipsychotic drugs, they are no longer deemed as being more effective. In this therapy, an electrical current is passed through the non-dominant side of the brain with intentions of rebooting internal circuits in the mind to function properly. There is a great risk when passing an electrical current through the brain, and this is now used as a last resort treatment. Finally, we will discuss psychological treatments for schizophrenia. A common form of psychological treatment is cognitive behavioural therapy. CBT is used to mediate feelings and behaviours, reinforcing the thought processes. It aims to challenge negative thoughts, demonstrating that they are irrational and wrong. It then aims to change the behaviour into desirable ways, challenging behaviours as well as cognition. CBT has become recognised as an effective intervention for schizophrenia, although there remains an ongoing debate as to the effectiveness and how long it will last. Whilst there is evidence for treatment of positive symptoms, it has not been shown to treat negative symptoms. Generally, availability of CBT for schizophrenic patients remains generally low, which may result in a higher use of drug treatment as they are more accessible for patients. Then there is family intervention therapy. With high expressed emotion within families, as explained by the social explanations for schizophrenia, there is a need for family intervention therapies as there can be a devastating impact on the family dynamics when living with a schizophrenic. Family therapies allow for views and feelings of all family members to be expressed and shared, building confidence and communication within the family. However, as a consequence of psychosis, social networks are reduced. 30% of schizophrenic sufferers are unable or unwilling to identify caregivers, disabling the use of family intervention therapy. Other psychological therapies are behaviour interventions and the increasing use of yoga and mindfulness meditation. It is important to remember that there is no cure for schizophrenia, but symptoms can get better with treatments. Thank you for watching.